Plenary session. I'm Wietske Fokkens, and I'm very honored to introduce the first real speaker of this Congress, Professor Hellings from Leuven. Professor Hellings is the founder of the EUFORIA, the European Forum of Research Education, and professor of otorhinolaryngology in Leuven University, Leuven Medical Center. And he is, I think, one of the very few that has a broad scientific interest that really goes from rhinoplasty, facial plastic surgery, where he's going to talk about today, to very basic science. And he's probably the broadest ENT surgeon I know. So it's a great honor to introduce you, Peter, and thank you for starting this Congress with the future of rhinoplasty.
Thank you very much, Wietske. What an honor to be introduced in such a way by my former mentor and person who inspired me to go into the path of rhinology one day. So when I started my PhD in '97, I talked to Wietske, and she was one of the persons who really took me to the higher level, combining research, surgery, and also defining what is really needed in this field to move this field forward. I have been asked to lecture about the future of rhinoplasty, and this is a challenging title, but I like to share with you some of the concepts and some of the work that may move the field forward. And I just give you an update of where we stand today. So today we know that rhinoplasty is a well-developed surgical field with an expanding facial plastic surgery subspecialty. You all know that within the ERS there is a big interest and growing interest in facial plastic surgery beyond rhinoplasty even, and there is increased awareness on outcomes and patient satisfaction, which was not the case when I started my career 25 years ago. But there remain many weaknesses because most of the focus of research is still dealing with objective outcomes. Can we improve the shape? Can we improve the nasal patency? How can we deal with several techniques without taking into account what really matters in rhinoplasty, which is patient satisfaction? There is a multitude of techniques and schools, and the younger generation is getting confused, which is not a surprise. Also, several specialties are involved. Quite often patients ask us about what is the best rhinoplasty surgeon. Is it the ENT surgeon, the facial plastic surgeon, or the maxillofacial surgeon? Well, that's a very pertinent question because many specialties are involved in this kind of surgery. There is the challenge of prediction of success. We all know what is reported in literature, but does that really account to your own practice? That you have to ask yourself. There is an underestimation of the psychological impact of rhinoplasty. And just to give you an example, I had a patient committing suicide 2 years ago after a rhinoplasty of mine. She sent me a message that she was very satisfied with the nose, but she realized she would never become the person she wanted to be. So the psychological impact of rhinoplasty should not be underestimated, and it still is. About 1 out of 4 or 5 rhinoplasty patients may enter into a revision surgery, and also the talks that we often hear at meetings are more marketing talks than educational talks. And I see Wietske laughing. That means that she would agree, I think. Anyhow, this all implies that there are some threats, especially for the junior generation, who may be confused by the different techniques, the different opinions, the different visions by different schools and surgeons. And also, some surgeons are really threatened by their patients, and that is something that I will also briefly touch upon. But there are opportunities to move the field forward, to improve outcomes, to improve patient satisfaction, and also reduce the likelihood of revision surgery. This was just a teaser, an introduction of this lecture. Now I will disclose my conflicts of interest, which are actually none. In relation to this talk, I don't have any conflicts of interest apart from the fact that I'm quite passionate about delivering a patient that is actually satisfied about the results. Not that I should be satisfied with what is delivered, but the patient should be satisfied, and I run a European Rhinoplasty course. Those are my conflicts of interest. I will talk to you briefly about the aims of rhinoplasty, the current state of art, future approaches, and then one of my favorite topics, which is 3D technology in the rhinoplasty field. I should remind you that for me, the first aim of rhinoplasty is to provide patient satisfaction, to make sure a patient would be satisfied with the results. And the second aim is only to look for objective improvements like improvement of nasal patency and or improvement of the nasal function. And patient satisfaction is really the key and is not always corresponding well with our satisfaction. And all rhinoplasty surgeons know that very well. Sometimes we are surprised that patients are satisfied with a specific result and vice versa. So it's not always a direct correlation between satisfactions. And even if we feel like Mr. Bean at the end of surgery, I'm always very careful because we can never 100% predict that also patients will be satisfied because of the psychological impact that this surgery has on patients. We know that when you compare patient satisfaction between different facial plastic surgery procedures, that rhinoplasty is at the lower end of the spectrum. And we also know that rhinoplasty patients have a difficult profile, especially those patients that come to see you in a tertiary care referral center. And this was one of the study reports that was a report in the New York Times based on the study that was performed by Dr. Valerie Picavet in our team. And this study was taken up by the New York Times, stating that 1/3 of the patients that come to see me for rhinoplasty have symptoms of body dysmorphic disorder. So we should not neglect that. Of course, I speak here of a tertiary care referral center, where the most challenging patients are seen, and there in that patient population, applying the standardized BDD questionnaires, we find that 1/3 of our patients have symptoms of BDD. This does not mean they have the full BDD syndrome, but they do have BDD symptoms, and these patients put you sometimes at risk. And being at risk means that you also can be threatened by your patient, and a study in the US already showed that those doing rhinoplasty and facial surgery may end up high in the ranking of surgeons who have been killed by their patients. So having said that, we should be careful, and when we talk about rhinoplasty, this is what we routinely perform in the preoperative counseling and clinic before taking a patient to rhinoplasty, but I'm convinced that this does not suffice. We should go a couple of steps further, and I will guide you through these steps, but first I need to tell you about the concept of precision medicine, which I think applies not only to oncology, also to the medical field and also to the surgical field, and I think rhinoplasty is an ultimate example of precision medicine, where personalized care, prediction of success, prevention of dissatisfaction and revision, and also patient participation in the design and the whole workout of the process are critical key factors of success. So I will guide you through these 4 pillars of precision medicine and disclose what is the current stage of our action and what could be considered more in the future. First of all, if we predict satisfaction, we rely on outcome studies, satisfaction studies, and within our institute we have run all the trials showing prospectively outcomes after primary and secondary and multiple revision rhinoplasty, after cleft lip rhinoplasty, and for instance we do know now, for instance, that 10% of patients after a cleft lip rhinoplasty delivering an excellent aesthetic result have impaired breathing. And this is really important to inform the patient about before taking them to the operation room. We need to tell them that the likelihood of aesthetic success is, for instance, in my patients, 90%, but there is a risk of impaired breathing, and that occurs in 10%. So I can give precise information to my patients based on the outcome studies that we have performed in the past. There are outcome evaluation scores that can be applied very easily. Valerie Picavet developed a BDD screening questionnaire, which is also very convenient. But if we go one step further, I think we should also mirror what happens nowadays in the CRS field, which is going to registries where we quantify outcomes and where we have a real-life impression of what rhinoplasty is all about. Open access data should help patients also to guide them to the one or the other surgeon with better results. Actually, a TripAdvisor for sinus surgeons and for rhinoplasty surgeons would be needed and would also help the patients, preventing others doing the same. And I like also the concept of a digital personalized follow-up of rhinoplasty patients as is currently done in the CRS field and asthma field by Galenus Health. If I consider personalized care at present first, well, in the preoperative phase, I see my patients 3 times personally, 2 times at the outpatient clinic and 15 minutes before surgery. So all patients are at least seen 3 times before surgery. I implement more than 1 2-dimensional morphing session in every single patient because it helps me to guarantee myself that this patient will be satisfied with the result that I aim for. We apply the BDD screening questionnaire and also informed consent on the procedures and the expectations. And also I inform them that the likelihood of them needing revision surgery in my patient population is 5%. Filiolekakis did during her PhD thesis all the analysis prospectively of 1,000 rhinoplasty patients, and we have now these satisfaction rates which really help me to inform the patient properly about the procedures, how I carry them out in my institute. When it comes to the perioperative phase, well, we develop a personalized surgical plan. I always carry out nowadays also end-of-surgery iconography because it's very important to inform the patient how the nose looked like at the end of surgery, especially if you apply trauma-reducing procedures. There's not that much swelling, there's not much blood, and you can really show the patient at least that you did major efforts in order to achieve the agreed goal. And last but not least, also in the post-op care, there should be a personalized follow-up depending on the grafts, depending on the lifestyle, depending on, for instance, a cleft lip nose with specific actions to be undertaken in order to achieve the best possible result. The future is definitely more into personalized care with involvement of 3D technology, and I will guide you through this during the last couple of slides of my talk. What I also consider the future of personalized care is these kind of cold versus powered instruments. So far, I have not been very fond of powered instruments because they made me deglove the soft tissues more. I had a couple of unsuccessful attempts with the piezotome and the piezo surgery, massive hematomas, whereas with the small cold instruments and chisels, this was a 5-minute procedure without too much problems during osteotomy. So I'm not so fond of powered instruments so far, but that might change in the future. Just using some small diamond burrs or whatever without going too much into the commercial aspects of what is currently being promoted by some of the colleagues. Also, preservation rhinoplasty has become a brand now, has become a very potent marketing tool. I think there we need to be very careful and carefully analyze outcomes of people who advocate this technique. They should show outcome data both at aesthetic as well as functional level, because I'm always afraid that with the preservation rhinoplasty, and I've seen some numbers of some excellent colleagues and excellent surgeons giving rise to major nasal obstruction problems, and that is something that I'm also afraid of. Implants should be considered in relation to the previous history and with actually the best implant. And I implanted titanium implants about 12 years ago because I was not so much convinced about the safety. I've done 10 patients and they all do well. In the meantime, over 1,000 patients have been implanted with titanium implants, and I do believe they have an added value. Unfortunately, I cannot go more in detail, but also going in the post-operative care, we need to understand better the endonasal healing, why there is 1/3 of patients, for instance, after PDS that have long-term swelling beyond 3 months. We need to also understand better why some patients remain to have external swelling. We are doing the trials now where we look at the mediators that are released after osteotomies, which is a controlled nasal fracture, and that helps us to understand what is ongoing in a particular patient population and how we can modify and improve the healing in the future. Prevention. Prevention may mean many things, like prevention of complications, prevention of dissatisfaction, and prevention of revision. We should work on all three together. Prevention of swelling, hematoma is done by cocaine gauzes, adrenaline gauzes, cold packs during and after the surgery. Prevention of scar formation and infection is actually done also carefully during the post-operative care with local ointments, with prevention of nose picking, and all what we deal with when we follow up the patient personally. And there again, personal follow-up is important. Also, resorption of rib cartilage is especially prevalent in those who smoke. Smoking patients undergoing multiple revision surgery should be advised not to continue smoking or quit smoking first before you invest a couple of hours on a nasal reconstruction using rib cartilage. Prevention of dissatisfaction here again is about proper patient selection. And nowadays I refuse 25% for patients that come to see me for rhinoplasty. That's a large percentage, and we're doing a trial together with Emmanuel Prokopakis, Yanis, also Gwede Adriaansen in Amsterdam and some others worldwide, where we define in about 300 patients that come to see us for rhinoplasty, for what reason we reject these patients to undergo this procedure. And I have now the first 100 patients, and it's nice to see that in 85%, it's just about person-related reasons why we do not consider this patient for rhinoplasty. And I think this has nothing to do with the complexity of the problem, it has only to do with the personality of the patient seeking rhinoplasty. What will then be the future of prevention? Well, I think we need to invest more, at least I need to invest more into optimal skin care in the pre-op and post-operative phase, which has been neglected by myself, and I should admit that. Overall general health conditions and lifestyle also play a role in healing and how well the tissues heal after surgery with or without excessive swelling. And Dean Toriumi had just written a book on healthy lifestyle and diet that may help to improve outcomes after rhinoplasty. And also better understanding of the healing of the nose will definitely be needed and help us in order to further improve the outcomes. But based on the last 1,000 patients of ours, we reach satisfaction after 1 year in almost 90% of the cases. In the secondary and the tertiary cases, it drops to 85 and 80. So we need to really understand in what patient population we can still improve outcomes. Participation of the patient is also a matter of fact at the time of defining the approach for surgery. So in the preoperative phase, we define what kind of technique would be applied. And depending on the age, depending on the preference, we do more or less efforts in the endonasal versus the open approach. And also grafting material is discussed with the patient because there is not one single ideal graft that is usable. So often we have the possibility to make a choice between the grafts, and every single graft is having its intrinsic advantages and disadvantages on the short and the long term, and I tend to discuss that with the patient. It takes some time, but in the end it helps them, I think, to achieve good patient satisfaction. And the future will also imply some technology. It may seem very futuristic and maybe a bit ridiculous at first sight, but I don't think it is the fact. Well, we use this Vitom technology, and we have now the 3D Vitom camera for 3D recording and also for educational purposes. This is the technology developed by the Storz company, and the likely benefits is that it would allow you to perform the surgery in a more precise way. It's a joyful experience to work with this device. There are, of course, some medical legal benefits of recording your surgery as well, and it definitely has educational events, advantages in tertiary care referral center. The benefits for the patient still need to be proven, and there I'm not so convinced about, but anyhow, I think this is the first 3D technology that we could consider. What we have implemented into daily practice is 3D morphing, and 3D morphing has some benefits because patients tend to understand even better what it's all about. In 2D morphing, you have limitations depending on the angle, and with the Photoshop program, we have limitations in about 10 to 15% of the patients, and these are the patients that we then select for 3D morphing. It helps the patient to understand better the ambitions of the surgeon as well as of the patients, and it helps them also to decide whether or not they should undergo the surgery. Filio Lekakis studied all of that. She was the one involved in our institute dealing with this 3D morphing in our patients, and actually the studies that came out and were published in in plastic reconstructive surgery all show that, look at the third graph, that patients really love it. They love the attention, they love these 5 extra minutes of attention and 3D morphing because they've never had it before, at least not in most centers where I've seen rhinoplasty being performed. So patients really like it, and as a matter of fact, when we evaluated not only the patient's opinion, but also the surgeon's opinion, for a surgeon it could be kind of considered like a time loss, but most patients, they like it, they appreciate the efforts being done by the surgeon. And for the last couple of minutes, I now go to the 3D printing, where we are currently finalizing some studies where we show the unique value of 3D printing also in rhinoplasty. So in the complicated cases, mainly complicated psychological patients, we tend to do 3D printing, and we have now a large number of patients in which we printed the face, the actual face, and also the morphed image. It's nice to have these printed models in the OR. It's nice also to show that for the benefits, it allows the benefits for the surgeon are mainly related to better patient selection. Because in some patients, after they have seen this model and this imprint, they know better what to expect, so it helps them to also proceed or refrain from surgery, and the same is true for the surgeons. These models can also guarantee you that you can get rid of these difficult patients. So this is something that I consider also as any of the future option. What I especially liked is to have at the end of surgery a comparison between your own end result and what the patient aimed for during the surgery. So it's really pleasant to have these models also around in the OR. I know it's a bit fancy, it may look like a toy, but for now I think in the more complicated cases, especially those with previous revision surgery or those where you reconstruct and significantly augment the dorsum, I think it's really a good way forward. So I hope to have convinced you that these 4 pillars of precision medicine, personalized care, prediction of success, prevention, and also participation, are key pillars of surgery or key pillars of satisfaction after rhinoplasty. And if you want to know more, I kindly invite you to attend our European Rhinoplasty course next year in April, where we have already 140 registered participants, which is amazing in COVID times. But anyhow, there's also Euphoria, which I also represent here. Euphoria aims to implement optimal care in patients suffering from chronic respiratory diseases, both in the upper and the lower airways. And in that context, also nose surgery, sinus surgery, and rhinoplasty are part of the portfolio, besides asthma and COPD. Having said that, I thank my research team in Leuven in the center. This is the hardcore research team dealing with immunology and the neurologic mechanisms of rhinitis, sinusitis, and asthma. And the 4 people around are those dealing with some clinical trials in rhinoplasty, especially Filio Lekakis and Valerie Picavet, who will also lecture tomorrow and the day after tomorrow. I thank you for your attention, and I wish you a good continuation of this wonderful meeting. Thank you so much.